Namaste, everybody. Thanks for the invitation. It's an honor for me to be here to discuss about artery disease and the approach to etiological diagnosis. So I have no potential conflict of interest to disclose. And thank you. Atherosclerosis, which affects large and medium-sized arteries, arteriolosclerosis, that affects mainly small perforating arteries, and heart disease, each of them account for approximately 25% of ischemic stroke, meaning a total 3 causes 75% of stroke. Unusual causes are responsible of only 5% of strokes, and this includes other artery diseases. And after investigation, stroke remain unexplained in 20% of patients. So of 80% of patients with a diagnosis, 3 causes explain 75%. So it's important to remember, and that it's a part of the rationale that I will discuss. So the pattern of the 3 common causes most of the time can be recognized from clinical evaluation and baseline tests. And the baseline investigation includes a brain CT scan. In most cases, it's really simple. Brain CT scan, vascular imaging from the aortic arch to intracranial arteries, EKG, Holter, and transthoracic cardiac ultrasound, as well as baseline blood tests. But sometimes, patients may have unusual causes, and these can be suspected from uncommon manifestations or baseline test results that do not fit with the usual patterns. In these cases, additional tests are indicated, and these can include MRI, vessel wall imaging, as was discussed, transesophageal echocardiography, prolonged monitoring, vasculitis, prothrombotic or genetic workup, as well as CSF analysis and other tests as needed. So the objective of this lecture is to recognize common artery diseases causing ischemic stroke, and mainly to detect manifestations suggesting uncommon artery disease. So actually, this is the approach that I use to diagnose stroke etiology. So let's start with a recognizable pattern. Arteriolosclerosis occurs mainly in patients aged above 40 years with hypertension and presenting with one of the 5 lacunar syndromes that are most common: pure motor, pure sensory motor, ataxia, hemiparesis, or dysarthria, clumsy hand. On brain imaging, it's possible to see single or multiple small deep infarcts or microbleeds or both, as well as periventricular white matter changes. And because the vessel changes are below the resolution of vascular imaging, most of the time these tests are normal in patients with arteriolosclerosis. So let's start with an example of an unusual pattern. This 36-year-old nurse presented with a pure motor stroke, looking like arteriolosclerosis. She was known for cigarette smoking, hypertension since 3 years, and migraines with visual auras. And she was on perindopril and hydrochlorothiazide. There's a red flag. The young age of this patient is unusual for arteriolosclerosis. She's a bit young for this disease. And also, she reported an episode of upper limb numbness 3 years ago, and she did not consult for that. Also, there was a mood change since 2 years with depression and an apathetic mood. On brain CT scan, there were white matter changes that were not exclusively periventricular. So these are in red flags that suggest that it's another etiology than arteriolosclerosis. This is why brain MRI was requested, and it showed small infarcts and extensive white matter changes affecting the temporal poles, subancillar regions, as well as the superior frontal lobes, as you can see. So a diagnosis of CADASIL or CARASIL was suspected, and this will be discussed later. So the red flags of genetic small artery disease, like in this case, are extensive white matter changes in young adults. This is also true for other diseases associated with mutations on COL4A1 and A2, FOXC1 and TREX1. Atherosclerosis now is also a disease that with recognizable pattern. Like arteriolosclerosis, it affects adults aged above 40 with vascular risk factors, and with atherosclerosis in other vascular beds like the lower limbs or the heart. And these patients present in general with non-lacunar syndrome and brain imaging non-lacunar infarcts. And these infarcts can be lobar of any size or deeply seated but larger than 15 millimeters diameter. Vascular imaging. On vascular imaging, we can see multifocal plaques. This is important. For example, in a patient age 45 with a dissection, we don't expect plaques elsewhere. So the presence of plaques in other locations support the diagnosis of atherosclerosis, and these plaques are eccentrics, can be ulcerated and calcified, and they are located at sites of flow turbulence, especially the aortic arch, the origin of the common carotid artery and vertebral artery, the carotid bifurc and siphon, MCA, as well as the basilar artery. These are typical locations of atherosclerosis. Patient 2 is an example of an unusual pattern, age 26, so right from the start, an age that is inconsistent with atherosclerosis. His past medical history was unremarkable, and he was on no medication. His current problem was he was backpack trekking in the Himalayas, and he developed left-sided neck pain since 3 weeks when he presented with a non-lacunar left MCA ischemic deficit. So young age and neck pain are major red flags for unusual causes, because atrial fibrillation, atherosclerosis, and arteriolosclerosis are not associated with pain, headaches, or neck pain. Whereas unusual causes of ischemic stroke, there are many of them that are associated with pain, especially dissection, RCVS, migraine-associated stroke, cerebral venous thrombosis, eclampsia, etc. Many unusual causes of stroke associated with pain. So these are important red flags and common red flags for unusual causes. On brain imaging of this patient, there was a non-lacunar lobar infarct, and on vascular imaging, vascular changes that differ from atherosclerosis. And for diseases, unusual diseases, the vascular changes are often recognizable. In this patient, there was a typical flame-shaped stenosis, which is consistent with traumatic dissection, and traumatic dissection can be recognized because of pain. Stenosis that typically is at least 2 centimeters above the bifurcation or affects the V3 segment of the vertebral artery. And on the T1 FAT-SAT MRI, the crescent sign can be seen, as you can see on this MRI here in the crescent sign. This type of multiple stenosis is consistent with FMD, fibromuscular dysplasia, which affect mainly females. 95% of patients with FMD are female, and it affects the middle third of the ICA. This ugly stenosis, if I can say, is quite typical for radiation arteriopathy, which causes stenosis limited to the field of radiation therapy. So big stenosis, large, irregular, and the other vessels are typically normal elsewhere. This is consistent with RCVS, multiple sausage type of stenosis, and the RCVS can be recognized clinically by the thunderclap headaches, and on imaging by the presence of multifocal stenosis that progress over time. This, by contrast, this single stenosis, fusiform stenosis, is consistent with PACNS, primary angiitis of the central nervous system, and this will be discussed later on. And basically, patients present with subacute to chronic headaches, acute to chronic infarcts on the brain imaging, CSF inflammation, and vessel wall imaging is very interesting, as was discussed before, showing concentric wall enhancement. This is typical of Moya-Moya disease, as was discussed just before, and typically there's bilateral distal ICA N1 and the A1 stenosis. So the take-home messages of this lecture are the following. 3 main causes. I did not discuss AFib, but it will be discussed after this presentation. But AFib, arteriosclerosis, and atherosclerosis, 75% of strokes. So I have these in mind, but when the picture, the clinical picture or the investigation results are inconsistent with these causes, then I open my book of differential diagnosis and I try to find the explanation by additional tests. And the second take-home message, the approach to etiological diagnosis is pattern recognition. This is actually the case for any discipline of medicine, pattern recognition, so this is important. Clinical markers of an unusual cause are many, but the 2 main markers are young age and neck pain or headache preceding stroke. You can have a headache after a stroke because of the inflammation of the volume effect of stroke, but neck pain or headache before stroke is a red flag for an unusual cause. And our radiological markers of an unusual cause, which includes the changes on brain imaging that can be seen with small artery disease. Vascular imaging is normal with small artery disease. And the changes on vascular imaging for medium to large artery disease, often it's recognizable even for unusual causes of stroke. Thank you for your attention. I'm available for questions.
We'll have a couple of questions. Dr. Lanthier, it was interesting about the radiation changes you've shown on the large arteries.
I'm sorry, I did not hear the question.
Radiation-induced vessel wall changes. What is typical? Is this something we have seen some patients who have had some radiation to the jaw, and sometimes intracranial disease also.
Okay.
Not related to the site of exposure of the radiation. Is that something we've seen?
Yeah, okay. So first of all, with radiation therapy, there are 2 possible physiopathologies. One is endothelial dysfunction, and the other one is endothelial dysfunction as causing accelerated atherosclerosis in the field of the radiation. And the other one is fibrosis of the vessel. And actually, if you look at the skin just above the vessel, if it's fibrosis, often you can find that the skin is fibrotic also. Versus if it's atherosclerosis, the skin should be fine. So with either fibrosis or accelerated atherosclerosis, there can be, the changes can be right in the field of radiation therapy. But if the stenosis occurs in a young patient, then collaterals can occur, and you can find changes that was discussed with unilateral Moya-Moyas. Like the example that was shown, actually, it was a unilateral Moya-Moya, and it would be consistent with the findings that can be found in patients with radiation therapy at a young age. So that may be an explanation of what you were discussing.
Thank you very much.
If there are any more questions, thank you, sir.
Thank you.
And hope we had a wonderful session on focal vasculopathy and visceral imaging. Congratulations to the organizers for selecting the speakers and the topics.